Hey, this is Sandy,
And Randy.
and we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. We have an education episode this week, and we are talking about neck pain.
And if you are listening to this within it being our latest 5 CU episodes, then super thank you to Precision AT, who is releasing this as a free CEU episode.
That's huge.
If you are not, then go ahead and scroll down to the show notes and you can go ahead and purchase for bonus content and to get your CEU credit.
Yes, absolutely.
You want to get started?
Yeah. Let's start talking about why this is a pain in the neck.
I was waiting for what you were going to come up with for
Yep.
this.
I was thinking about it all morning. All right, so what we're going for with this episode is we're going to describe the anatomy of the cervical spine and its role in neck pain. We're going to discuss some different treatment strategies to treat neck pain and a little bit of the evaluation process. And then we're going to discuss the rehabilitation strategies to correct the dysfunction associated with neck pain.
And if you tune into our bonus content, I will also be showing some treatment strategies
Yes.
and some manual therapy, I believe.
Yes, Sandra is very good at treating neck pain. She's gotten pretty skilled at it.
I could talk about cervical spine all day.
All right, so starting with the anatomy real quick, we're going to divide it up into, you have your deep flexors for the cervical spine. So that's made up of your scalenes, in particular the middle, which is the largest. I didn't really know that. So that was pretty cool. I think it's important to note that the middle scalene actually attaches to the transverse process of the atlas. So it's up there. And it's going to have a big role in controlling those upper levels of the cervical spine. And then you have the posterior scalene, which kind of blends with the middle. So it's going to have a good important role as well. And then you have some other small ones like the rectus capitis anterior, the longus colli, and the longus capitis.
I haven't even heard of the longus colli, actually.
You see? Look at it. We're all learning new things.
So I have a really good scaling stretch that I recommend for people, especially a lot of people who are doing everything in front of them all day. Whenever I'm treating neck pain, I always say, it's really tough because everything is in front of us.
Yes.
Like we have our people who we're talking to, your phones, if you're reading, if you're sitting, anything that we're doing is like in front of us. I'm not going to sit back to back and talk to you and then try to arch my back and try to listen to you, right? I'm going to sit and engage and listen to you and lean forward. And so everything is in front of us. And so a lot of times we get so stuck in this anterior body. So what I recommend is, in addition to treating posterior structures, but also working on mobility in the front and strength in the front. So I have a really good scaling stretch that I show people, especially when I'm like, oh, you've been sitting on Zoom all day. So I'll go ahead and put that in the bonus content.
Nice.
And also some deep neck flexor stuff.
That bonus content's growing. I like it.
I'm excited. I feel like usually you do the bulk of the bonus content.
Yeah. So this bonus content's pretty much going to be run by Sandra, so I'm excited.
All right, let's go back to our anatomy, Randy.
Yes. So those muscles, like Sandra was saying, are more towards the anterior side. And really, if you look at their origin and insertions, a lot of them originate from more lower cervical levels. Like some of them do reach around C3, but then you're looking at a lot of them attaching to C4, C5. So next group that we want to talk about is on the posterior side. And now we're actually talking about stabilization of the head to the cervical spine, and muscles that are really important for this that a lot of people don't really consider because they're really small. And also, it's kind of like, well, how much am I really affecting them is the suboccipital muscles. So this is your rectus capitis posterior major, rectus capitis posterior minor, obliquus capitis inferior, and obliquus capitis superior. Now, the reason these muscles are important to talk about is, like I said, it really stabilizes the head to the neck. So it's really going to play an important role when we're talking about our head movements, which as an athlete, you do that a lot. You're rapidly moving your head. You need to have good stability with that movement. And what I thought was very interesting is these muscles actually show activity during eye movements. So your head doesn't even have to move. If your eyes are moving, they're firing. So it just shows how important they are to the stability. It's really cool how I found that out because I got this from Anatomy Trains, and they were talking about it. And they in the book it was telling them like, oh, like if you put your fingers right below the base of your skull and then move your eyes, you can feel the muscles fire. Oh, it blew my mind.
That is crazy.
I know. I was like, whoa. So I know the part everyone's probably thinking. I know the part Sandra's thinking is, okay, why do these muscles group matter? Like, why are we going over this anatomy? Why are we going over rectus capitis major? And I'm never going to use that again. And I think what's important to remember is the literature has shown that in patients with neck pain, both of these groups have shown decreased activity. So the muscles of the suboccipital muscles, the anterior deep neck flexors, and of course the deep neck extensors like the multifidi, like the cervical multifidi, the rotatorus, those are all in the same group, have shown to have decreased activity. They're not firing like they would, which means the stability of the spine is coming from somewhere else whose job it is. It's not really their job to necessarily provide that stabilization, like your upper trap or your SCM, sternocleidomastoid.
It's a good muscle.
It is. So essentially, when you're looking at neck pain, it's a similar idea to low back pain. If these deep muscles that are in a great position to provide stabilization aren't firing correctly, you're going to see other muscles not in the position to do it try to take over, and this is going to lead to more pain because now the cervical spine is compromised. It's not as stable as it should be, and that's where issues are going to come from.
So deep neck flexor exercises are actually so simple, but I feel like that's kind of like an eye-opening for people. Like, oh, I actually can't hold this.
Yes, absolutely. And also, we can't talk about the cervical spine without also talking about the thoracic spine. You know, clearly there is a connection between the two, but we will also talk about why the thoracic spine should be looked at in your evaluation and treatment of cervical neck pain.
So do we get to go into evaluation now?
Yep, let's do it. So I like it when these like clinical guidelines come out or like these new models come out and they divide difficult pathologies into different categories. I always like reading them. I feel like it keeps me organized when I'm doing my evaluation. So neck pain can be divided into 4 subcategories to guide your treatment. There's neck pain with mobility deficit. So essentially that's someone who's having central or unilateral neck pain, and as the name describes, limitation in motion, and that limitation could recreate their symptoms. On your exam, you're going to find, again, limited cervical range of motion, and they'll get pain at the end of range of motion, and this is either active or passive.
Is this like a certain range of motion or any like flexion, extension,
It could be
flexion,
it could be any of
rotation?
them. I do know like when you look at like cervical spine evaluation, everyone loves looking at range of motion. Mm-hmm. And the literature from what I've seen, it gets kind of mixed on like if people with neck pain truly have a deficit in range of motion. And I think this is why you can see not good consistency within the literature, because they're just clumping everyone into neck pain, mm-hmm. whereas they're not looking at it from 4 categories. So I'm sure clearly the people if you put a research study with just neck pain with mobility deficits, they're going to find like, oh yeah, people with neck pain have limited cervical range of motion. So I think that's the limitation in a lot of this literature, is they're just really clumping, oh, well, you have neck pain, get in that study, as opposed to dividing them into the 4 categories.
Right.
Now, in an acute setting, will they have deficits in strength? Probably not right away, but if it continues, you'll probably start to see deficits in strength for more like subacute or chronic cases. So if you have an athlete that comes in who's like, oh yeah, I can't turn my neck for the past month, all right, you probably have strength deficits at this point.
Right, because muscles are just like hanging on.
Exactly.
Relying on their lack of length, their tightness.
Exactly.
Strength.
Absolutely. And we've also talked about how pain affects the motor system.
Right.
You know, so these muscles are going to start turning off because of the pain as well. The next subcategory is neck pain with movement coordination impairment. So how they describe this is kind of like whiplash. And what I thought was very interesting that I never really thought about but makes sense is you can also kind of throw this one in with concussion.
Mm-hmm.
So the symptoms that they describe in this category are obviously if there's a trauma, and it may present with concussive symptoms. So your exam findings are a positive cranial cervical flexion test, the positive neck flexor endurance test, which we will throw these into our bonus content as well. Any strength deficits, that could be present as well. And then their neck pain around mid-range of motion that gets worse as they get closer to the end of the motion. So, as athletic trainers, depending on the setting you're at, you don't really get a ton of whiplash because every time when you think of whiplash, it's like a lot of motor vehicle accidents. Obviously, with certain concussive events, you can get whiplash, of course, but this might be another good idea to think about when you have someone with a concussion who might be suffering from some neck pain.
I had a patient with whiplash.
Really?
Yeah, in the performing arts setting.
That's tough.
It was a character who got hit in the head, but because of the way that the mascot costume was, like it had a really long snout area, her head went into complete cervical flexion and extension.
Ouch.
Right. And she ended up having bilateral numbness and tingling.
Oh, I remember
down
this
her
one.
arms, and then also she was having trouble swallowing.
That's concerning.
Right.
100% concerning.
Right.
So the next one that a lot of people do consider is neck pain with cervicogenic headache. So symptoms of this are a non-continuous, and what I thought was interesting was unilateral neck pain with associated headache. So that's interesting that they were categorizing this as unilateral. So only one side of the cervical spine's hurting. And then the headache is aggravated by certain neck movements or sustained postures, which I know I'm the model of forward head posture.
We're working on that.
Sorry, I meant perfect posture, right, babe? Was I right the first time?
I think you were right the first time.
So the exam for this one is a positive cervical flexion rotation test, limited cervical range of motion, especially in the upper cervical spine. So that really goes back into influencing the upper levels when you're treating neck pain. And then, of course, strength, endurance, and there will be coordination deficits. And the final subcategory is neck pain with radiculopathy. So that's getting your neck pain with radiatum symptoms, upper extremity dermatome, myotome symptoms. And your exam findings are anything positive for Sperling's, traction, or the upper limb tension test. And what they really wanted to point out is that, especially on median nerve testing, if you get a positive on median nerve testing, you probably have some cervical spine stuff going on.
Not good.
So then those are the 4 categories that kind of help organize when you're looking at someone who has neck pain. So hopefully that can help organize your thoughts of like, okay, where am I going to classify this person? Because it will help your treatment. Other deficits that you can see with neck pain, as with what we talked about in our low back episode. If you haven't checked out our low back episode, I can't remember the number, but go back into like our directory and stuff. And that was a really good CEU episode as well. People with neck pain have displayed poor sensory motor control, so they're having poor proprioception of their cervical spine. How they really did a lot of these measurements I thought was interesting. They looked at like acceleration and velocity of like range of motion, which I thought was different than like any other thing they look at for this stuff. Like obviously repositioning was off, and like they had them follow a target with rotation, and then they had more errors. So that shows.
Oh, we've done that.
Yeah.
You put a laser on their forehead and then you just like have them turn.
Yeah. And like that was shown to be altered, but also the speed. People with neck pain tended to move their neck slower than someone who had a healthy neck.
Interesting.
Yeah, so it's just showing there's a lot of poor coordination going on between or within the muscles of the cervical spine. And then they also, along the lines of poor coordination, they found a very slow movements between the cervical spine and the thoracic spine. So the thoracic spine is influencing our neck pain as well. And when you think about it, some of the more superficial muscles that attach at the cervical spine, like some of your erector spinae, also attach to the thoracic spine.
Well, also, if you think about if you have a dysregulated breathing pattern, the scalenes are directly involved in assisting to lift that rib and that chest in breathing, and then and that's in the cervical spine.
Oh, 100%. We haven't even talked about how important the diaphragm is in cervical neck pain as well. I mean, again, a lot of this stuff is following a similar pattern as low back pain. And in low back pain, they found that, patients with low back pain tend to have breathing dysfunction because they're having poor control of their diaphragm. So you can probably safely assume that is going to be the same for neck pain.
I agree.
All right. So we evaluated. Now it's time to dive in.
Actually, really fast.
It's not time to dive in.
Just an evaluation thing that I just want to say, just realized yesterday. I deal with a lot of cervical spine.
You do. You have seen a lot of neck pain.
But this was actually, I was working with one of my students on neck pain and neck evaluation and treatment, and we were going through all the range of motion and everything. Now, I know I have limited active range of motion and rotation of my cervical spine. I didn't realize that I have full passive range of motion in my cervical spine in rotation.
Interesting.
So that's something that, honestly, that's something I kind of skip in my evaluation. I do passive range of motion, flexion, extension, but not fully passive rotation. And I think there's a lot of value to that. And that might be something that we might be skipping, because I feel like sometimes range of motion is just a little bit skipped over.
Yeah, a little bit.
Right. Or someone who's having neck pain and you don't want to move them into that,
yes,
into that range of motion, but it could tell you a lot.
And of course, remember, we are talking about more like insidious onset neck pain, right? Obviously, if there's a traumatic event, you do want to make sure there's no cervical spine fracture, and you want to make sure, you clear that first, of course, but
unless you're my doc who's standing over me while I'm holding C-spine on a football player, and he tells me to check range of motion of his neck. Yeah,
that one was tough.
Yeah, that was a little interesting.
So getting into kind of like, okay, we now have this problem. What are we going to do about it? And I think that's very important that we need to dive into, because a lot of the stuff that I was reading about neck pain is a lot of people tend to get neck pain at some point in their life, and it is very hard to treat. And
I mean, how many people have come up to you and said, "Hey, I slept wrong last night"?
All the time. Oh, especially, or I've gotten like jumpers, like pole vaulters and high jumpers, because just how they land in the pit sometimes. But also, like rehab, it's a lot of times neck pain's gonna like reoccur, and it's very resilient to treatment. And what I was reading is for some certain neck pains, you only have a 6 to 12 week window to make a lot of progress, and anything outside of that, progress is going to be really slow. So it's really important to like, hey, if you have a neck pain, like, all right, let's get going. Like, let's start. Let's not let this linger. Obviously, if there's a mobility deficit present, there's a lot of good evidence that manipulation and even just mobilization are beneficial into decreasing that pain, improving that motion. If manipulation is warranted, use that referral source, for someone that can perform those maneuvers. But even simple joint mobilizations have shown to be beneficial. And there's actually evidence that a manipulation or mobilization improves the sensory motor control of those suboccipital muscles. So now you're getting improved motor function just from a simple treatment.
Nice.
So you do your treatment, and then you jump into your exercises, and now you're really optimizing that motor system.
There's a lot of mobilization you can do in the spine. You could just do simple as joint play and with the spinous processes. But you can also do joint play with the transverse processes. You can do assistance with rotation.
Absolutely. And for what I was looking into, for cervicogenic headache, there's a lot of good support for using like a Mulligan technique on those upper levels of your cervical spine. And I mean, it was actually recommended in the, the Journal of Orthopedic Sports Physical Therapy. like in their clinical guidelines, they actually put that technique specific for that. So it just shows how valuable that is.
I do a lot of Mulligan technique on my...
I love Mulligan technique. Also, a lot of these conditions, at some point, strengthening of the deep muscles is encouraged, especially in those conditions that have been going on, which I don't know if you've noticed, but our athletes like to come in after it's been going on for 2 weeks. I thought it was going to go away, but it didn't.
Wow, that sounds exactly like my athlete.
Oh, 100%. So it's probably just safe to assume you're going to do, some kind of deep muscle exercises for this. And in acute cases, what I think is important is like you can do it, I think, first just, hey, let's maybe decrease their pain first, and then you can throw in those exercises once that happens.
Right. And again, like the deep neck flexor exercises are so simple. I feel like a lot of times I tell people one of them you can do sitting in the car, like while you're waiting at a stoplight. And no one's going to know because it just looks like you're thinking, because you literally just put your fist under your chin. Like it looks like you're thinking. Yeah. And then
all the people watching on YouTube are like, what? What are you doing?
There are a couple ones that I tell them, you can do this first thing when you roll on your back. Or depending on how you sleep, just like wake up, roll on your back, roll on your stomach. Just do a little deep neck flexor work, just like some endurance. And like, it's a great way to start your day too. So it's like, you don't have to take time. It's like you're already doing these things.
Oh, 100%.
You just have to think about it.
You just have to start it.
Right.
So I think overall the biggest takeaway kind of follows what, if you've taken like any of the SFMA courses, what they kind of talk about is fixing mobility first, if that's present, and then jumping into the motor control. So it's really focused on, hey, let's get mobile, and then let's start talking about motor control, which is consistent with what we're seeing with neck pain in general, right? Like the mobility deficits, they really wanted you to, hey, work on that mobility. If it's a chronic case, then start working into your rehabilitation exercises. So I think that's the biggest thing. And I think that really highlights the key when you do have someone with neck pain, as with any evaluation, what we should be doing is looking at range of motion, because that's a deficit that, we can easily try and take care of.
Another good treatment strategy is just simple manual therapy. And sometimes this doesn't mean like digging into the neck, but is following the pathway of the scalenes with your thumb, just a really light motion. And usually I have them supine. I have their neck laterally flexed to the opposite side of what I'm trying to work. So if I'm trying to work the right scalene, I'll have them laterally flex towards their left and then rotate towards their left. And then I'll go ahead and take my thumb straight from like right behind their ear and go all the way down to that clavicle, first rib area. Just being careful of the carotid artery.
Of course. Yes, manual therapy is definitely key, especially for like obviously mobility stuff, but also muscle trigger points. Sometimes you can get some trigger points with these conditions as well. And that kind of leans towards like, okay, well, what about modality use? And I think modality use is just, what you need for like if you need to start working on like, oh, well, let's lower their pain. There's some support for like laser because of the trigger point stuff. If you found great results with that, like awesome. That's definitely a nice tool to have. Same thing with ultrasound. Like obviously ultrasound has been recommended for trigger points as well. And I've seen some pretty good results with someone who had like persistent neck pain or at least persistent trigger points in their neck. And we started using ultrasound or even the combination of ultrasound and stim. And made a huge difference on that athlete. So definitely go within your clinical judgment. There's nothing wrong with using those modalities.
I haven't used it personally, but I've also seen pretty good results with passive.
It's like, I think it can either be positional release technique.
Yeah,
I think.
that one.
It kind of follows the same idea too as strain counter strain. Mm-hmm. Like I know there's a difference between the two, but they're very similar. Essentially, where you put the body segment in probably the most comfortable position for the athlete. So whatever they think is the most comfortable, you let them rest there, and then you're palpating that point of pain. Mm-hmm. And then what you're trying to feel for is a certain point that area is going to pulse. It's going to start throbbing, and then it'll just kind of let go.
Just relax.
Just relax.
Traction is another one that I use. Other than the neck pain with radiculopathy, did you do any more reading on traction for treatment?
Not specifically, but that has been advised, especially for the neck pain with radiculopathy, because the idea is, that's going to relieve the symptoms
and create space.
Exactly. So that one for sure was very supportive of that. The rest of them, if it's going to work, like if you've noticed it work for your patients, I'd say definitely go for it, especially with someone who is having those mobility deficits, because then you're able to get some stretch into the capsule. That might be all right.
Right. Also, traction with like light rotation. You can kind of find transverse processes on both sides when you're doing traction, and you can rotate the cervical spine in one way and then the other way, and just kind of get that almost like guiding that motion.
Absolutely.
Do you have any other treatment or rehab techniques, Randy?
No, hopefully this makes treating neck pain a little less of a pain in the neck.
Starting and ending.
I had to bring it back. That was the only one I got. That was the only one I had for this episode.
I approve. So, Randy, how many references did you use for this?
We were right around 12 to 15. The ones that I had, they were all pretty long. Took a lot of time.
Oh.
Yeah. Because there were a lot of them were like kind of like review stuff. And then the clinical guidelines for neck pain was 99 pages.
Oh, my goodness.
Yeah. But those ones are always fun to read. A lot of good information. A lot of quick information.
I'm glad you're enjoying yourself.
Yes. I'm having a blast over here.
So we're going to go ahead and put those on our website, which you can find below in our show notes, or you can just go to our Linktree/AT Corner Podcast. We also do every other episode as education or stories. This one was an education, and like we said before, this one was a CEU episode. Thank you, Precision AT. Next episode, we're going back to our stories, which if you would like to submit your story for a future episode, head over to AT Corner Podcast. We feature real athletic trainers and our own personal stories.
Yes.
We also have a Facebook group. If you are not part of it yet, go to facebook.com/group/AT Corner Podcast, where we will be posting questions of the week. You can also comment. We're probably going to post something about neck pain, so you can go in and see what other people do for neck pain. Obviously, we only know what we do and what people around us do, so it's really cool to see when you guys chime in, and we want to hear about what's been a pain in the neck for you and how you treat that.
And then lastly, we do have a discount code with MedBridge. So if you're kind of thinking, hey, like I need to start working on my CEUs, MedBridge is a great place to start. They have a great database with a lot of great quality content to dive into. They're easy to watch. Our discount code is in the show notes.
Cool, Randy. You got anything else?
Nope, that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.